Good afternoon, everybody, and welcome to this week's Power Hour. My name is Christina Nattuktag, and I am from the North Carolina Medical Society, where I head up the KIPL Institute for Physician Leadership. With me, I have my colleague, Aubrey Cuthbertson, and also, as always, our moderator for today, and every week, is Franklin Walker, who's also from the North Carolina Medical Society. Today we're going to talk about diabetes, and as you know, we are doing these Power Hours in order to focus on conversation, collaboration, and community. We're so excited about the guests we have in our Zoom studio today. We have Dr. Karen Smith and Dr. Brian Klausner. We also have a group from AMA, and thank you for being here. We have Shannon Haffey, Siga Vasaitis, Nora Rankinson, and Janet Williams. As always, we want this to be an informal session, an informal hour. This is your hour, and we encourage you, if you have a question, don't hesitate to unmute yourself, or you can just put it in the chat box as well, and we will make sure that we raise that question. Please be on mute as you don't talk, as we want to prevent the background noises. And also, just so so everybody's aware, we are recording this session as always, and you will be able to access this after on the KIPL landing page next week. Without any further ado, I'm going to hand it over to Franklin Walker.
Thanks, Tina, and welcome everybody to this edition of our Power Hour. As Tina said, we've got two physicians that are with us as well as a contingent from the AMA. So let's set the stage for our talk today, first by talking about diabetes from a national level and what the AMA has put in place for several years. So I'd like for Shannon Haffey, who's with the AMA, to give us a quick overview of what the AMA has done historically. Shannon?
Great, thank you, Franklin. I'm Shannon Haffey. I'm the Director for Client Strategies and Partnerships at the AMA in our effort to improve health outcomes. And thank you to the North Carolina Medical Society and to all of us for hosting this very creative discussion today. We've actually shared this concept with others at the AMA, and they're pretty impressed with the quick pivot and the idea. And in particular, we want to extend our appreciation for all of you during the COVID-19 pandemic. Your work, your dedication, your commitment to patient care. Many of you are on the front lines of helping our nation, and relevant to today's discussion, also to preventing chronic disease that is increasingly looking to be associated with adverse outcomes of the pandemic. So thank you. For background, as the AMA promotes the art and science of medicine and the betterment of public health, it is that second part of our mission that brings us to you today. Together with my colleagues, we represent the mission at the AMA that is designed to improve health outcomes, where we focus our work on working with physicians and practices to prevent cardiovascular disease. And one of our key priorities is diabetes prevention. We've had a long-standing partnership in this space with the Centers of Disease Control and Prevention and others like the North Carolina Medical Society in order to identify patients at risk with prediabetes and refer them to a diabetes prevention program. So today I'm joined by my colleagues, Janet, Nar, Siga, Jenny, who all work with clinical practices to help institute a clinical workflow that integrates identification and referral. Our goals at the AMA are to help patients, help physicians help patients, including trying to reach 2 million people who have prediabetes over the next couple of years and help them reach treatment, including referral to a diabetes prevention program. In the past, our work has been to work with physicians and practices around the nation to do things like implement retrospective patient identification algorithms, look at point of care opportunities, leverage patient education in the office setting, build referrals into electronic health records. And so we aim to serve all of you and to represent your voice as you practice medicine. In our time of doing this across the nation, we have concluded that there are so many pieces that have to line up to make referral to a DPP successful that we felt with CDC we need to dedicate all our efforts in one place. So When we work with payers, can we do that in one place where we work with the physicians? Can we bolster the network of diabetes prevention programs in that same location? And that is what has brought us to focus in North Carolina. In North Carolina, in your state, there's actually a number of programs available. The Medical Society has long identified public health as a priority and has experience on this topic. There's a large number of primary care physicians and health organizations who reach even the national level in their commitment to the prevention of chronic disease. On the CDC side, they've invested in the public health infrastructure to prioritize diabetes prevention. And notably recently, last year, Blue Cross as the major payer in your state has agreed with this as a priority, and they're increasingly funding diabetes prevention as a covered benefit. So that brings us to be very dedicated in your state, and we wish we could visit right now. But last year we ended up approaching Franklin and the Medical Society on this topic and working together, and we felt like we had a great opportunity to improve the health of those living in North Carolina. So we're here to hear from you, to answer questions. We're interested in what you have tried, what works, and what you need in order to identify patients who are at risk and refer them to a program. So thank you for having us, and we look forward to the discussion. Franklin?
Thanks, Shannon. That's great to tee this conversation up. We know in North Carolina about every year there's 50,000 adults that are diagnosed with type 2 diabetes. And as Shannon said, we've tried to put together this program, and we have many partners that have formed DiabetesFreeNC, from the Medical Society to the AMA to the Department of Public Health. We have about 30 partners in this enterprise. And as part of it, the North Carolina Medical Society and the AMA have put together a group of physician champions. And we have two of those together with us today, Dr. Brian Klausner and Dr. Karen Smith, both who are primary care physicians, both who are chief medical officers for their respective ACOs. So they're seeing it at a granular level, at the practice level, and also at the macro level with a system. So I want to get involved with a discussion with the doctors at this point, and let them give us a little background on how they have been practicing DPP within the confines of their particular practice. So Dr. Smith, can you give us a little bit of background on how that works with your practice, please?
Thank you. Our practice is heavily data-centered as well as patient-centered. And so to use data has been quite important for us. We are able to utilize our electronic health record as well as our ACO data. And as a local medical director for the Alidate ACO, it is a wealth of information that we were able to gather from not only our commercial payers, but also our public payers such as Medicaid and Medicare. The information obtained at the point of care and the practice with the patient, and to take all of that lab data as well as the risk factors of the patients loaded in, and then we had the ability to query our system and then to implement workflows that would allow us to identify those patients who are at risk and hold that conversation and make those recommendations to say, what can we do to help prevent the onset of diabetes and the complications associated with diabetes? And that's pretty much how our office is doing the workflow to get a hold and get ahead of diabetes in our region.
Thank you, Dr. Smith. Dr. Klausner, can you tell us a little bit about your practice?
Yeah, I mean, I think, as you said, there's both kind of a personal clinical perspective that I have when I'm managing my individual patients, and then there's a chief medical officer perspective from a population health perspective, and they both overlap. To Karen's point, how you kind of proactively push this and promote this in the clinic. So using analytics in order to identify, all right, these are our high-risk patients. These are our patients. And I think all of our EMRs are able to do that to some extent where like, I want to filter my A1Cs between 6 and 6.5. We want to make this more of a systemic process that involves kind of a team-based approach. So when that patient comes in, we'll remember it and we'll be able to offer that as a potential intervention. It's very consistent with other things that we're doing, both, again, at the individual patient level, at the ACO level, where prevention is getting more and more prioritized. Like the easiest case of diabetes to treat is the one that never occurred in the bud when your A1C, when you identify an A1C of 5.9. And I really low-hanging fruit there, whether it's a dietary or getting them to exercise. And it's very consistent with this patient empowerment. How do we better involve the patients in their care? And how do we give them the tools and resources to do that, and how we do it systemically? So using analytics to identify the patients, working this into a systemic workflow with standing orders or flagging patients when they're in the clinic. I've seen a variety of different ways being implemented in our ACO clinics, and then having that conversation to get the patient the intervention they need to improve their outcomes. I mean, that's really what we're supposed to be doing in medicine, is working with our patients to improve their outcomes. And hopefully that's not waiting until their outcomes are severe and advanced and they're already sick. It's doing that earlier and earlier and doing it in a structured way. So I think a lot of it involves what Karen was saying around data analytics and kind of a systemic teamwork approach. And that has to be customized. What works in my clinic, it won't necessarily work in another one of our independent clinics. So I think each clinic, we share best practices, we show how we do it, and then each practice can kind of adjust it and pick it up on their own.
Thank you, Dr. Klausner. We've all been under the umbrella, if you want to say it that way, of COVID pandemic for the last 60 to 90 days. Telemedicine has become a real game changer for most physicians. So I want to ask both of you, doctors, how telemedicine may have changed the way you're treating and delivering preventative care, and how you might be optimizing that in your practice. Dr. Smith?
Telemedicine really has been the major factor allowing us to maintain contact with our patients. Our patients were sheltered in place, and some of them felt that, I'm alone, and I'm what do I do? And what if I need medication? And what if I have a problem? With telemedicine, whether it was televideo or telephonic, allowed them to hear our voice and we could hear their voice. If we were using televideo, we can see their face, we can sense the anxiety, and we were connected. The interesting thing about the pandemic, the coronavirus really opened up many eyes regarding our disparities, regarding the need for management of chronic disease. It really highlighted individuals who had obesity and diabetes and hypertension. And it was an opportunity for us to see, what can we make a change? Yes, certainly with access, but what about our chronic disease management? And now let's use our telehealth tools to do that. And that's exactly what we did. As part of the Alidate ACO, we were able to on-ramp telehealth to many of our practices across the country, and to say, remain connected with your patients. The lab data that you had previously used that information. The risk factors for individuals for getting diabetes, whether it was family history, use that information and hold those conversations. Implement strategy for the patients at home and maintain the connection. And by doing that, we hope to have had an impact on the management of all of their chronic diseases, but diabetes was one that we really could say diet, exercise, stress management and reduction, And if you were at risk of diabetes, let's prevent you from getting it, because there is the concern of a second wave. And we want you to be ready if it should come as hard as the first. So that was our strategy for utilizing telehealth.
Yeah, and
Dr. Klaus, go ahead. Sorry, Brian.
I once again agree with Karen, as I usually will. I think it was fascinating how quickly we were able to, I think all of us kind of were scratching our heads and saying, wow, that we were able to expedite standing up telemedicine and things that we've been thinking about for years. I think, like most clinics around the country, very, very quickly. And personally, I love it. I mean, I think one of the issues that we've had historically with our flawed healthcare system is that it's been very medicine centric. It revolves around our silos and our hospitals and our clinics. And we realize, like, we're artificial environments. Like, the vast majority, and everyone knows the stat, it's used all the time, but the vast majority of the health outcomes that we are supposed to be managing, and now the associated costs that we are now held accountable for, have nothing to do with these medical silos that we have kind of arrogantly sat in and let the patients revolve around us. 70, 80% of all health outcomes have to do with what the patients are doing in their daily lives, the 99.9% of the time that they're not in our hospitals and they're not in our clinics. And for me, one of the things I've always loved as a physician is home visits. And I don't do them a lot, but every now and again, if I have a certain patient that can't come to the clinic, historically I've gone to the home. You learn so much more about the patient when you go do a home visit and you see them in their environment, and that's where pathologies live. That's where healthy lifestyles either live or don't live. And so it's just been kind of cool, I think, with these video visits, because you kind of go in their home and you're in their environment, and that's kind of the way it should be. And I think we're all looking up and we realize a lot of this is going to stick, that these video visits are going to continue past COVID-19. To Dr. Smith's point, I think is an important point. Primary care absolutely has a role in mitigation strategies with COVID-19, because we know a lot of the risk factors with COVID-19, and our patients realize this because, everyone's paying attention and reading stories and visiting CDC. But, things like smoking and being overweight, like those are all risk factors. So if the second wave comes, or, in the next year, if a patient is exposed to COVID, they're going to do a whole lot better with that infection if their weight goes down, or if they're not smoking, or if they're eating right, or if they are being healthy. And so it's kind of I think an opportunity with the video visits to get more in the environment of the patient, and to promote things like lifestyle changes, things that in the short term will have an ROI, right, a return on investment, because it might help them not get hit by COVID hard if they do get infected. But in the long term, obviously, it has impact as well. And so a lot of that preventative stuff, when you say prevention, you think about mammograms and colonoscopies, things like that. But we also should be and do think about just healthy lifestyles, the main things that are really going to drive health. And I think that video visit capability is much more useful in addressing those coaching aspects and seeing them in their home. I had a patient couple of weeks ago that took me around their kitchen, and for the love of God, we saw some things that diabetics should not be eating. And you just learn so much more than having that appointment in the office. So I think it's here to stay. I think it's awesome. I think we can leverage it into more of a coaching and following up and quick drop-ins, and the reimbursement systems will have to kind of fall in line and figure it all out. But it offers a more patient-centric, sometimes quicker touch base, more of a dynamic, ongoing relationship, rather than, I'll see you in my office every 3 months or every 6 months. We'll talk for 10 minutes, and I'll see you 6 months later. So I think there's huge potential with it, both from a chronic disease management, but also from a preventative / healthy lifestyle perspective as well.
Quick follow-up, Brian. How do you feel your patients have either liked or disliked this move to telemedicine?
For the most part, I think people really enjoy it and are getting hooked on it. So I think you're going to get some patient demand around sustainability with it. For the most part, I haven't had many patients that dislike it. And I think if you're really paying attention, there's a lot of pretty cool interventions around can you supplement the video visit with home phlebotomy or home radiology? I mean, all this, there's a lot of interesting innovation going on right now, but for the most part, it's intuitive because, and there's some visits you can't do via video visits. Sometimes you have to bring them in, and we're bringing them in safely when we need to bring them in. But you realize there's a lot of things that we can do that we've done historically in traditional office visits that we can do pretty easily with video visits, or even better. And I think that lifestyle coaching, healthy lifestyle prevention might even fall into the even better category with video visits. It seems to be a better platform for it.
So Dr. Klausner, this is Janet. I know Franklin probably has another 3 follow-ups, but I really am intrigued by what you're saying. And as Shannon mentioned, here at the AMA, I work with health systems and predominantly with the clinical teams and large systems. But I like, and one thing that actually came up last week is this idea of coaching, right? That typically and even from typically in person, sometimes we tend to educate. And I think that we now really need to pivot more coaching. And I think it's going to be really exciting to see how that coaching concept dovetails with what's happening with the diabetes prevention program, which even those facilitators are figuring out, okay, I've got to be a coach virtually. But how do you think this is going to play out? You know, you said some of these visits make more sense. You know, as we're looking to prevention is really now at everybody's top of mind. First, we thought when COVID hit, nobody wanted to know about preventing anything but COVID.
Mm-hmm.
And so I'm wondering, how do you think as you look to wellness visits, and certainly with the older adult population, I mean, I know especially I'm looking at Dr. Smith, you know, the ACOs, you want your wellness visits with Medicare. And so I'm wondering, how do you think your colleagues are now going to start looking at wellness and prevention? Because certainly when you're talking about managing patients who already have type 2 diabetes, those visits around the kitchen become obvious. Mm-hmm. So how do you think this is going to now look if we stay with coaching and we stay with telemedicine and how do we start bringing back in wellness? Because certainly if somebody's coming to you for a telehealth visit on managing their asthma, but they also have to be obese, you're probably not going to start looking for prediabetes. You know, you're going to do that acute visit no matter what. So I think I keep asking the same question 5 different ways. So I will just put myself on mute.
Yeah, I'll take the first stab and then I'll turn it over to you, Karen. I think if we don't leverage this, there's short-term opportunities that we can leverage into long-term sustainable interventions and approaches. I think there is an opportunity. I think patients are very, as we know, are very nervous, are very aware, are paying attention. And I've seen it kind of go both ways. It's really interesting. I've seen a lot of patients who are decompensating from a lifestyle perspective and who are gaining weight and not exercising. And then I've seen a lot who have gone the other way. And I've really used this as an opportunity to become healthy and realizing a lot of their motivation is to minimize their risk around COVID-19. So I think it's shining a light on a couple of things. COVID-19 is shining a light on a couple of things, and it's just one example of the way our healthcare works. Dr. Smith mentioned one, this healthcare discrepancies where we're looking up and saying COVID-19 is hitting different populations disproportionately. I think a lot of us are saying, yeah, that was pretty predictable, right? Because it's the same thing that heart disease and everything else does. So healthcare discrepancies is one. Another one is just the importance of healthy lifestyles and how we coach and how we approach that. Again, the easiest case of COVID-19 to treat in the ICU is the one that never went to the ICU in the first place because the patient lost 40 pounds and stopped smoking. That's great. The easiest case of colon cancer, it's synonymous, is the one that never occurred because of the colonoscopy, or the easiest case of diabetes is the one that you prevent it because the guy stopped drinking a 6-pack of soda and started exercising in 2020, so he didn't have to have an amputation in 2035. And so I do think patients and doctors are realizing that and putting that into context a little bit. And then I think you're right. Like we just had an ACO webinar about 3 days ago, where we started talking about, guys, we can't neglect what we do as primary carers for a prolonged period of time. We put some things on hold in the last month or two from a mitigation strategy to flatten the curve. Now that it doesn't look, as long as we're careful, that for now, there's going to be a catastrophic collapse of our healthcare system, we got to get back on track, or else we're going to see chronic disease outcomes worsen than we have in certain nations. We're going to see breast cancer to go up if we're not doing preventative care. So part of it is leveraging what we're doing right now with COVID-19. The other part of it is realizing what we do is primary care. And I think, Dr. Smith, I don't know if you've seen that, but there's been more conversations nationally, I think, and definitely locally, is we can't neglect chronic disease. We can't neglect healthy lifestyles, and we can't even neglect preventative care. We got to get back on track, or else that could be an undesired consequence of not only the COVID-19 related acute deaths related to COVID-19, but heart attacks, strokes, breast cancer that we see because the reaction to COVID-19 compromised what we could do from a preventative and a chronic disease management perspective.
And I would agree. One of the tools that we utilized with our ACO data was a COVID-19 vulnerability work list. And we were able to stratify who were the patients at very high risk of having bad outcome, either disease or death, if they should come in contact and actually have the COVID-19 virus. And we risk stratified them. We had very high risk, average, and who were those individuals? And so the workflow was designed to reach out to those individuals, whether we did telephone or televideo. But then it was very interesting. Okay, so we're contacting them, and we may even say, we're concerned. You're at very high risk of having not a good outcome if you come down with COVID-19, and we want to do everything that we can to optimize your chances of survival. That's kind of a scare tactic. And it dawned on our team, we have to learn how to coach people, how to encourage them to actually change their diet, change their lifestyles. If you're sheltered in place, don't just sit there on the sofa looking at the numbers every single day. We want you to get up and move. How do we coach individuals and encourage them to adopt healthy lifestyles that make sense? We definitely did not want people to go back to where they were. And likewise, with all of us in healthcare services, we really do not want to go back to where we were. We want to take this opportunity that we have been taught by coronavirus to do better than where we were. And for physicians, we need to coach our colleagues, and we need to coach our patients, and we need to come up with different strategies in terms of how we communicate and how we engage. Because what we were doing before, it wasn't working. And so now let's make use of this opportunity and utilize these new strategies. The COVID-19 vulnerability work list was a great tool for us to use. And now we can do the same thing with our DPP, get our pre-diabetes, get that work list as part of population health, and let's utilize the coaching tools. And if we don't know what those tools are, let's get trained and educated so that we can communicate better with our patients than what we were doing in January and prior.
I completely agree. I think one strategy around this, who's not a great health coach is me. That's not one of my strengths. I'm trying to be. And like I see Dr. McCrary on the chat room there, to be an MD and a newly trained health coach. That's awesome. Using team-based approaches is key, right? And that's been a foundational aspect of population health, and even the NCQA patient-centered medical home model. But really approaching this from a team-based approach, and not only a clinical team like the patient-centered medical home, but in value-based care, as we can continue to push, community-based teams. So increased community collaboration with with experts. Like YMCA is one of the members that we use here for DPP. They are the experts. They're a lot better at this than I am. And so to be able to tap in to, it's not just me and my patient on an island anymore. It's a team-based approach, but we have to start thinking of team-based approach outside of the medical field and into the community-based organizations that are experts in how you do this, because they're a lot better than I am. So,
can I ask a question? Because you make me think. Both of you are talking about what this COVID-19 has done in terms of shining a light on all the discrepancies and the socioeconomic disparities and how that impacts. And both of you make me think about. So I have a question with regards to And I was kind of thinking about that, Dr. Klausner, with the community-based approach, right? But what have you seen? Because we can talk about, let's say we get the patients to do the tele visit, whether by phone or by video, and let's say you have excellent coaches that coach on nutrition and, you know, being able to prevent and treat this up front. What if they don't have access to healthy food? Like, what if they're in an area where, you know, we can talk all we want, but the realistic aspects of that for that patient is non-existent. So they'll say yes and yes to you because they don't want to let you down as their physician, right? But then in reality, the system is simply not put up in order to foster and promote that kind of living. Does that make sense?
Yeah.
What are your respective thoughts of that?
Yeah.
Both of you.
Well, I think, to Dr. Smith's point earlier, I think COVID has shined a brighter light on this. I think there's been historic healthcare discrepancies that are inhumane, that are avoidable, and are inhumane because they are avoidable, and they are really expensive, which makes them idiotic, right? So it's one thing to be inhumane, it's another thing to be idiotically inhumane if the inhumanity and the inefficiency leads to increased healthcare costs. And so it's a really kind of a no-brainer argument that to better treat from a public health perspective these healthcare discrepancies, you need to get outside the siloed healthcare systems and a fee-for-service system where we just get paid when people are broken, to really managing population health, really holding, and I think that the payment models as they evolve are facilitating that, because no longer, you know, as we evolve away from fee-for-service to value-based care, we're going to be held accountable for the cost of care of our patients. And there's a cost that comes to the medical communities, there's a cost that comes to the government, there's a cost that comes to Medicaid, Medicare. So I think it's working to advocate to shine a bright light in an effort to address the inefficiencies in a way that will improve outcomes, and by the way, lower costs associated with those bad outcomes. So you kind of see example of that here within Blue Cross. So there's been in North Carolina, Blue Cross has been a great partner supporting DPP, and they brought in grant funding for this. So in certain locations, patients can get this for free or a subsidized rate. So I think leveraging off to treat the chronic healthcare discrepancies, while they are inhumane, inefficient, and expensive, they're also complex, and it's going to take us as a community to figure this out. I think us advocating for that and being part of that community membership in advocating for change is key. So that's why when Blue Cross came out and supported this through grant foundations a couple of years ago, I mean, it really resonated with providers and with systems. But it's up for our patients aren't going to know about it unless we tell them this, unless we educate, take the time to learn about this, and then take the time to talk to the patients about this and walk them through how to do it. So it takes a lot of work and effort, but it's important both from a mission perspective, but also from just a cost efficiency perspective.
Yeah,
So kind
Dr.
of,
Klausner?
yes,
Yeah, I was just going to say that it's back to, you know, if we go back to basics, right? It's that multi-pronged approach, right? So it's hitting up people where they live, work, learn, play, and pray, and whether that's a community-based policy, whether it's higher taxes on sugar sweetened beverage, or, you know, the built environment, whether it's systems within your EMR that make the default choice, so the physicians are going to run a registry of patients with prediabetes, or running that vulnerability checklist, right, Dr. Smith? And even from treating prediabetes, right? You start with lifestyle. Is there something else if people need some, you know, if they're not just in the DPP, you know, what is, you know, we all have different ways of dealing. So what are the multi-pronged things that need to happen in the doctor's office? What needs to happen in the community? What needs to happen in the program realm for people who are involved in an intervention? You know, I mean, it's funny, it's back to, you know, the team-based care. So how do we take sort of those tenets, right? If we go back to patient-centered medical home, and as I said, go back to basics with maybe some new learnings about, as Dr. McCurry was saying, about coaching. And she and I actually were just exchanging some text messages, practice transformation. But I'm also really curious, I want to go back to this team-based approach, because I think we might have been paying some lip service to it. And so how do we, it's everything, how do you make things sticky? And I think to Dr. Smith's point, we may have that advantage because of what COVID has taught us. So I'm curious, from both of you, maybe others, who are here, what they sort of think about what can we do to really make team-based care sticky, and how do we do this multi-pronged approach that, meets people where they live, work, learn, play, and pray.
The team-based care is absolutely important, and there's no doubt about it. But I also want to emphasize that relationship that the patient has with their provider of care as being the starting point of initiating that conversation. Brian was talking about his patient walking around the kitchen, showing all the different foods. Well, Brian, my patient was in the John, and he was doing his telehealth visit. And I said, you can't get any more trusting than that, okay? And so that's like the epitome of the patient-physician relationship. And I captured his attention. And so if we can start with that and encourage those doctors and our providers of care to hold that conversation. And I also want to go ahead and say we need to pay attention to the primary care spend. We need to pay attention to how much are we paying our practices and our physicians who are providing primary care in relation to what we are paying in other arenas. Are we paying enough finances, enough cash to allow these practices to really start that conversation? Are we paying enough to really morph out and develop teams either in our practice with health educators, with our behavior health individuals? Have we allowed them that ability to put these services into place? And whether we do it in our medical home or whether we have set it up so that we are accessing resources outside of the medical home and not being stretched to having the hamster wheel approach. I have to get in and see that patient within 8 minutes. So I believe once we can achieve that, we can really maximize in terms of what we really do to have an impact on patient care, that physician-patient relationship to the team-based care and utilizing what we have in our community settings. And from that point, I think we're going to make a difference. We're not going to do what we did pre-COVID. We are going to really make a difference in people's lives and decrease the morbidity that we're seeing with chronic diseases like diabetes.
Yeah, I mean, think about it. I think to support what you're saying, Kathy, largely depend. If we keep getting paid to fix things, and then things are going to keep getting broken. As we evolve into value-based care, and we're truly held accountable, even from a long-term across the outcomes of our patients. I mean, think of the value of a DPP program that, $100 to empower patients, not only for their elevated blood sugars, for everything. I mean, think of all the positive benefits of a DPP that focuses on diet, exercise, patient empowerment. The long lesson in that is so incredible relative to, again, 50 years from now, the ICU stay after he gets a leg amputation and he's blind and on dialysis. I mean, the ROI on these things is tremendous. And when and if and how, reimbursements catch up to that and realize that and actually incentivize that, I think that remains to be seen. We're moving toward value. It's going, slower than I think a lot of people thought, but until you get a compensation model that truly supports that intuitively, I think we're gonna struggle. If you flip the switch on that and you become an ideal value-based care, then all these things are going to change. I guarantee utilization of DPP programs, other preventative programs, patient empowerment, home visits, all those things would escalate dramatically.
I want to ask a question to our AMA colleagues. You guys have a really unique vantage point because you look at all the states, and we've talked about the tools of telehealth, and Dr. Smith has mentioned the COVID-19 work list that's been so great for her ACO. Have you guys seen anything other than what we've mentioned on a national basis that we should know about?
I'm thinking through both like with the expansion of telehealth, but also just in our experience with diabetes prevention. Let me think about that. Let me also, we have a group, it's not our area, but we have another group at the AMA that is really focused on the expansion of telehealth, the expansion and creation of waivers with CMS around telehealth. And there might be a couple of ideas or content that surfaces there. But a lot of what you're discussing is I'd say best practices. Not everyone has done that. We're starting to see some practices that probably did telehealth for a month to survive kind of retracting. But the team-based care, the leveraging of telehealth, those to me feel like sort of the exemplar of what we see. Janet, can you think of anything that's more diabetes prevention specific that's different?
No, I think I from the clinical standpoint, actually the only thing I've been hearing is that for going back to the doctors who have been really sort of working on the wellness and the healthy lifestyles in their televisits, they actually said that the visits are the telehealth, and I think for what you pointed out, Dr. Klausner and Dr. Smith, they've actually been more productive because you can see people in a different light. But I think from the diabetes prevention standpoint, I think what I've been hearing is some clinicians feel more comfortable, oddly enough, talking about what we sometimes think of as these difficult conversations. And maybe it's because you're seeing people on their turf and not, in that medical setting, which is, at least if we're talking about preventing diabetes, it doesn't happen in the medical setting. It's going to happen out in their homes and where they live. So I think that's kind of some of the mind shift we've been seeing, but we certainly are really need to see enhancements in telemedicine, and certainly that value-based approach is something that other members of Shannon's team have been working on for many months, and I think we're getting more support there as prevention is being elevated for things when you look at hypertension and diabetes. So I'm more optimistic about sort of that value-based approach, as you were saying, Dr. Klausner, where you're seeing more people who will actually use the DPP, because it does have this value.
Well, it's interesting to kind of get to one of the questions you had asked earlier. I mean, one great way to make it stick is to put like system workflows together, right? So it's similar to standing orders with a urine micro. When a patient comes in, they're due for a urine micro, you can put a standing order around that. And you combine those standing orders with maybe EMR data, kind of what Karen was saying earlier. And I was thinking, as I contacted our local YMCA, Susan Pettengill, on my way as I was driving in, and they started virtual DPP classes, so they can do their education. They're doing it virtually. And then I started thinking, what better time than now to, look at my EMR, do a report of all my patients, A1C 6 to 6.5, and get them in a virtual exercise, diet, education, patient empowerment class. Like, why aren't I doing that, right? Or at least having conversations. And you can do bulk letters, you can do outreach, you can send portals. So, how do we make it stick, and how do we prioritize it? A lot of times putting system-wide, and this is a lot of what ACOs do, what we try to do with our ACO as well. You put workflows or best practices together and make it, instead of, oh, that's a good idea, maybe I should do it, and then I forget about it in the next minute because of ADD. Like, why not make it kind of a workflow, like a system workflow, and make it more of a structured approach, so you can ensure that there's that safety net where you're calling all those people, at least offering, right? I mean, that's the thing is, our job in medicine is to make sure our patients know their options to improve their health. So you're a diabetic, hey, this is your option. You have metformin, you have insulin, you have this, and these are the risks and the benefits. As a pre-diabetic, do a lot of our patients even know about this option? We educate them about a powerful, effective option that effectively is more, in studies, in that DPP study from 20 years ago, they compared this with metformin, and this was superior, significantly so. So, I think a lot of times we jump to medications and we talk about risk benefit, but I can tell you, I think most of my pre-diabetics, I haven't had a really intensive, informed consent discussion about this is a cool option. This is available to you. I think if I did, a lot of my patients would say, yeah, what, so but there's reasons why. We're busy, we're doing, so how do you make this a system approach, team-based approach to provide kind of a safety net to make sure that, patients who might benefit from it are actually benefiting from it?
Can I ask you a question when you say systems approach? When you say systems approach, do you mean the healthcare organization, or are you taking into account like the larger system? The system.
I'm saying from a clinic perspective,
from a clinic perspective. Okay.
People are joining and saying, well, how can I do this? I think a good best practice is work at the individual level of the clinic, develop this into maybe population health workflows that you're doing, and that might lead to kind of a workflow type of proactive outreach with a standardized letter.
Gotcha.
And hey, contact this, or this is more information, this is the number you can call. Rather than sitting there waiting for your pre-diabetics to come, and then you get so busy and you forget to talk to them about it and say, oh, damn, next time they come in, maybe I'll do it. Make it more of a proactive population health type initiative in the clinic.
Yeah.
And I wanted to elaborate, and that was one of the changes that we made in our workflow. We were utilizing a campaign called Call Us First, trying to decrease our emergency room utilization and encourage the use of the physician office, the medical home. But we changed it. Instead of waiting for the patient to call us first, we flipped it around and said, we're going to call you. And that's where the COVID-19 vulnerability work list certainly played a role. But then we recognized, even with improving our chronic care management, our CCM, and our transitional care visits and the AWVs, we're going to call you. And so we were calling the patients, we were reaching out, and we can certainly continue with that strategy beyond that of Corona and continue with the best practice in terms of population health management. We're going to call you. And when we call you, we're going to have some things to talk about, and it's going to be a benefit to you. So it's a little bit different twist in healthcare delivery from what we've known in this century of practicing medicine, or this era of practicing medicine. We're definitely going to see new things on the horizon.
I want to ask you guys, the doctors, we've invested a lot in DiabetesFreeNC with, patient education, provider education, which you guys are on the forefront of, with our North Carolina Medical Society AMA splash page with these toolkits that we've developed. But now that we're in a time of COVID-19, besides telehealth, is there anything that you all can think of that your organizations that are trying to help you with all this, AMA, North Carolina Medical Society, could bring to bear that would help you guys, not just with your diabetic patients, but with preventative medicine in general?
One of the areas of concern that we are seeing it is an escalation in the mental health problems. The diagnosis of anxiety is just unreal right now. We're doing the GAD-7, and I'm getting more positives on the anxiety scale. And so we really do need our behavioral health colleagues to assist us, and how can we connect? It's really going to make a difference. Quite frankly, we're not going to be as successful with chronic disease management or diabetes management if we do not pay attention to the chronic mental diseases as well as the acute mental issues that we are seeing. And that morphs right into what's happening in terms of domestic violence, in terms of behaviors that are being exhibited that perhaps would not have been exhibited. We really need to pay attention to our populations and what's happening to people on the streets.
Yeah, exactly. Exactly what you said. No, I completely agree. And we all expect, and there's been a lot of literature around this, there's going to be a second wave of, or whatever wave you want to say, but this wave of mental health exacerbations and new mental health illnesses. Excuse me, there's ambulances in the background, not my patients. But clinically, like 2 or 3 weeks ago, boy, it just hit my clinic, and I've been seeing a lot of it, and this is going to be here for a while. when you look at chronic, or you can look at diabetes, or you can look at any chronic disease, we did studies internally that paralleled Blue Crosses, that paralleled state studies, that patients with poorly controlled mental illness, their medical costs, not mental health related costs, their medical costs doubles. And so if you want to treat medical illness, you got to be better about treating mental health issues. And so to answer your question, Franklin, I think the more, similar to how we're dedicating, we realize how important diabetes is from a public health perspective, from a patient care perspective, and so we're going to increase our focus and attention on that. A lot of these classes that we're doing from a patient empowerment, there's been good data around the benefits of exercise, and specifically exercise from a stress reduction and anxiety depression perspective. But how do we build similar classes and community resources for people to mental illness? And again, both now in the short term for COVID-19, but this is something historically we haven't done well in medicine. Is this an opportunity to finally start addressing this as we see a wave of mental health issues? We work closely with our homeless community. We have an uninsured hotspotter model that we run at our hospital here. And we work with a lot of addiction programs, and we're seeing overdoses. We're seeing more suicide. We're seeing all of this. And so that's going to be yet another effect of COVID. It's not going to kill you with respiratory lung disease. It could kill you with a severe depression that leads to overdose or suicide. So this is going to become a pretty desperate situation for us, I think, in the next couple of months and going into a year or two. And how do we do this not only at the adult side of things, but even specifically, and even probably more importantly, from a pediatric perspective, because it's just something we haven't done well historically as a healthcare community. Is this an opportunity that we can do to leverage COVID-19 related efforts into more longer term outcomes to treat and to address a historic flaw of our healthcare system?
Okay. What do you guys think that in terms of examining the way we pay for behavioral health?
I think, and Blue Cross is doing a lot of work. Blue Cross North Carolina is doing a lot of work on this, but I think you have to look at, so much of it is access. So in the past couple of years, there's been so many psychiatrists and therapists that have gone cash pay only, which again is just going to worsen healthcare discrepancies because there's a lot of poor patients with severe mental illness that can't afford it and can't get in to see a psychiatrist now. So I think, again, if we go straight to value, if we were in a pure value-based world, you'd be investing heavily in mental health because you realize you could maybe lower your medical cost. And so along those lines, advocating for better reimbursements, both in the primary care perspective, reimbursing video visits, for telehealth with psychiatry, in a lot of studies is actually better than a face-to-face, because patients don't feel comfortable going to clinics. And now I'm going to a psychiatrist. I'm walking in the psychiatrist door, and so telemedicine is a perfect form for this. And so payment reform, payment restructure, paying psychiatrists, paying for mental illness, lowering copays, treating copays as you would as a primary care. So there maybe eliminating copays for mental health and reimbursing video visits, cognitive behavioral therapy. I think there's a lot they can, to answer your question, there's a lot that they can do. And in a pure value-based world, if you're just focusing on decreasing costs, a lot that they would do to help address this.
It's interesting because Brian said at least 3 or 4 times in terms of payment of mental health services within that practice. As a provider of medication-assisted treatment, I had a patient come in today who was fearful of going to the emergency room because he had injected heroin and now developed an abscess, and wanted us to take care of that here, which as a primary care family physician, we were able to do that. But then there's the counseling that needs to occur. And how do we do that in a setting and make sure that we have embraced this gentleman, not pushed him away, not push him into a setting where he's not going to go, he's not familiar with, and we end up with a bad outcome, we end up with the overdose. And so that the payment needs to be developed in such a way that we are able to provide those services, which we are quite able to do in that medical home, because that's where the patient has embraced his care. And so yes, we do need to pay attention to that. We also need to be very careful with providing telehealth services that are not centered from that doctor with the physician that the patient is comfortable with. We really need to be very careful of not shifting our patients to teledoc services that are generic and do not have that relationship with the patient. And likewise with mental health, we have to be careful with pushing our patients off into a setting that they're not familiar with and they're not comfortable with, but to make sure that we're able to have payment for those services where they are comfortable, which is in the medical home.
Right. We're getting close to the beginning of the top of the hour, but I do want to follow up on something both of you have mentioned, is the disparities and how they are unevenly affected during COVID-19. And I'm lucky enough to know you guys pretty well and familiar with your practices, and you serve a lot of the underserved in our state, high Medicaid, high uninsured. So I want to talk briefly, get your opinions on the differences, what you're seeing in how the disparities are happening here in the treatment. Brian, can you talk about that briefly?
Well, I think the disparities related to COVID-19 parallel the disparities that happen elsewhere in medicine. It's complex, it's multifactorial, it has to do with access, systemic stereotypes, and into an element racism. It is complex. From a social determinant perspective, social determinants, as we said earlier, drive 80% of all healthcare outcomes. And so similar to diabetes or heart disease, if you're living in a poor patient population, if you can't do social distancing, I can tell you specifically, I work a lot with the homeless. There was a lot of cool things that happened from a public health perspective from a homeless outreach, but when this hit, shelters closed, programs closed, food pantries closed. We had a lot of people on the streets shrugging their shoulders saying, what am I supposed to do? They get COVID-19 after being out in the storm for a week in a tent. Like, they're probably going to be at a higher risk, and that's why traditionally homeless die at 7 times the rate of a normal population from the flu. It's just very multifactorial, but a lot of it goes into inability to live healthy lives, social distance that predisposes, and then limited access to healthcare, and then sometimes how they're treated when they do get that access to healthcare. So it's a hard question to answer, but it is very multifactorial, very complex, and pretty haunting when you start looking at a lot of the factors that go into it.
And I can add to what Brian is saying, but I'm going to make it very brief. I'm going to say access, access, access. And I mean access to healthcare, to jobs, to housing, to food, to shelter, to any other services that any human needs in order to live. Access, access, access.
You are so much more articulate than me. Everything I'm trying to say, I say it in like 3 minutes and she nails it in like 10 seconds. Darn it. No, I agree. Access, yes, access to everything. That's a perfect answer. Absolutely.
And we can all remember that too. Okay, we're just about at the top of the hour. This has been a great conversation. I can't thank the doctors enough, and I want to thank our group from the AMA for supporting diabetes prevention in North Carolina and on a national basis. Tina, I'm going to hand it back to you.
Thank you, Franklin. I can't tell you thank you enough for all of you for being here today. We're so grateful, and I think this is a really great conversation that obviously continues. There's lots more to talk about, and there's one thing that's clear, and that is this is a community-based approach that needs to happen right on so many levels. Thank you to all of you who joined us today. Thank you to Dr. Smith, Dr. Klausner. Thank you to Shannon, Siga, Nora, Janet from the AMA. We loved having you. Please join us again for next week's power session. We will have the details up about that around Monday next week. So please be on the lookout for that. And again, thank you so much. Thank you for everything that you do out there. And if there's anything we can do to serve you in any way, please let us know. And we are here for you in any capacity we can. Thank you again and enjoy the weekend.